hospice care and provide an update. I guess the other thing that you were going to talk about is the renovation of the Halquist Center.
Right.
But Steve has a lot of really important information to talk about it, just in terms of defining the difference between palliative and hospice care, as well as the services that Capital Caring provides. So with that, Steve,
Terrific.
take it
Thanks,
away.
everyone. Thanks to A&V for having me today. Um, Very quickly, my background is I've been at Capital Caring Health for almost 5 years now. Prior to that, I moved down here to Washington from New York in 2010. And for 6 years, I ran all of the business and membership operations for AARP. That was my first real foray into being in a nonprofit organization. Prior to that, I was on Wall Street for almost 40 years, running marketing for some major companies like Amex, American Express, Citigroup, Fidelity. But I decided that I wanted to give back, and that's why I went to AARP when I was offered that job. And my very good friend Tom Consumpus, who has been CEO of Capital Caring for a long time, asked if I would join him, and I did about 5 years ago. Capital Caring Health was one of the first two hospice groups to begin operation in the United States in 1977. And Tom and a number of other people, including Robert Dole, former Senator Dole, were instrumental in getting hospice legislation passed back then. Our mission is very similar to yours in terms of focusing on aging in place. But in a few words, we care for everyone, regardless of race or citizenship status or ability to pay. So no one has to worry about a medical bill that they can't pay because there aren't any. And as I mentioned, we've been a not-for-profit since day one, and will continue to be. So let me talk a little bit about what we've been providing now for 46 years. Some of these services are much newer, but our core service, by the way, our service area is all of Northern Virginia, all of Washington, D.C., and about one half of Maryland. But we also do programs that extend to beyond our service area into the Mid-Atlantic region and also nationally, which I can talk about. But for hospice care, it's it's important to understand just a few things. If people enroll in hospice care sooner, they live longer. There are only two options at the end of life when you're considered to be terminal. And to enter hospice care, two doctors have to agree that best case you have 6 months or less to live. One would be an attending physician, and one would be one of our doctors. The hospice benefit was created by Medicare and Medicaid and private insurers for 6 months minimum, or more if necessary. And it's a shame and tragic that people only use it on average for a couple of weeks. And that, the way I like to describe it is, toward the end of life, you have two options: hospice or hospitalization. And which would a family and a patient prefer? Being cared for in their home, in familiar surroundings with family, friends, pets, or being in a hospital stuck with a bunch of machines trying to keep you alive in a sterile hospital room, and way too often, unfortunately, dying alone. And hospitalization is much more expensive to Medicare and Medicaid, and ultimately to each of us who contribute to that. So the other thing about hospice care, which isn't well understood, is we care for the whole family. So a family trying to go it alone with a loved one who's terminal has tons of stress, has to rush the loved one to the hospital, usually frequently, None of that is necessary. Absolutely none of that is necessary, because 95% of the time we come to the home or wherever they reside, assisted living facility, nursing home. And we have a team approach, which includes counseling family members with our social workers and our non-denominational chaplains, as well as our nurses and doctors. So we wish that more people understood the hospice benefit and jumped into it much earlier. On average, a patient that enters hospice sooner lives at least 1 month longer than they would in a hospital, where they're usually over-medicated and die prematurely. And that's a proven fact. Moving on, we also provide what we call primary care at home, or the medical term is palliative care. And that's for people who are chronically ill, one or more chronic illnesses, generally older, 75 or older in many cases, who are homebound. They can't get to the doctors. They can't, they're not easily mobile. And so we come to them, and we're available 24/7 by phone, one of our team members. There's no answering service. So there's no need to call 911. There's no need to try to, rush someone to the hospital, because we can be there at any hour of the day or night if that's necessary. And it's not just medical care. It's social behavioral care, again, for the patient and their family. The family is, like in hospice care, usually under more stress than the patient. We also do a home safety check. We also provide with palliative care, as we do with hospice care to the degree we can for the patient, diet, exercise, and not only indicating the proper diet, but also providing food free of charge if that's something that's needed. And we also note a lot of the time in our primary care at home program that patients have been over-medicated, and that various doctors they have used don't coordinate very well. That's not to dump on doctors, but we see it frequently enough. And so, we're able to make sense out of what they should be doing from a medication standpoint, with us as the focal point. And when a patient eventually turns terminal, it can be weeks, months, or years, then there's a seamless transition to hospice care, usually with the same team, providing that. About our inpatient centers. 5% of the time, a patient and family need comprehensive around-the-clock care. And it's usually toward the very end of life, usually the last couple of weeks. And if that's the case, we move the patient into one of our inpatient facilities. We have 2 operating at the moment. One is on the grounds of Sibley Memorial Hospital, which opened a little over a year ago. It's the only inpatient center operating in Washington, D.C., and available for Arlington residents as well. And the other facility we operate, which is a standalone, beautiful residential center, is called the Adler Center, which is in Aldie, out near Dulles Airport in Loudoun County. And these are the only 2 facilities that are operating in our service area. Why? Because it's very expensive, and we only get reimbursed by private insurers or the government about 50% of the actual cost. So in the case of Sibley and Adler, we lose well over $1 million a year providing this around-the-clock care. And we try to fill that gap through philanthropy. And I can talk about HallQuest in a few minutes, which is currently shut because it needs much needed renovation. Moving on to a few more things. We're the largest provider of children's hospice on the East Coast. And we're only one of 5 hospice organizations out of 4,900 in the nation that have a dedicated pediatric team. So in most cases, if a child needs hospice care, the adult team tries to deal with that, but they're not specially trained. And we don't think that's the right approach. We have a dedicated pediatric team. We care for 200 to 300 children a year and their families. It's a real special mission that we do that. And then for the family of a patient when they pass away, we provide bereavement counseling free of charge for as long as necessary, group as well as individual counseling, completely free of charge. It's not reimbursed by any insurer, but we believe that's our mission to do that. And we provide that community bereavement support for any other member of the community that gets a hold of us who needs it. They don't have to have had a patient relationship with us. And so we'd like more people to know about that. And then finally, we have a special focus on dementia. About 30% of our patients, whether they're in palliative care or hospice care, have some form of dementia, including Alzheimer's. And we just created a 64-page comprehensive guide for caregivers who have a loved one with dementia, everything you need to know, which you can download free of charge on our website. If you go to capitalcaring.org, it's currently highlighted on the homepage. And then Cheryl and I were talking earlier about, we also provide companion robotic pets. He's turned off at the moment. For dementia patients, free of charge. And we do this locally, regionally, and nationally. We, Capital Caring Health. And these pets, the vast majority of the time for people with dementia in the early and middle stages, and even in late stage dementia, except for the very end, these pets almost always dramatically improve the daily life of the dementia patient. I've seen it firsthand many times. It's pretty miraculous, from being agitated, confused, not really engaging with other people, family and friends, to all of a sudden becoming calm, friendly, happy, and naming the pet, keeping it with them. A lot of the time, medications they're on can be reduced, and their daily life is dramatically improved. It's pretty amazing. And so we have provided so far probably 3,000 pets across the country. And I continue to promote this pet program, dogs, cats, and birds. And they respond very much like real pets. Dementia sufferers in the middle and late stages can't handle real pets. They shouldn't be allowed to handle real pets, which they can inadvertently harm. But giving them a pet gives them a real sense of ownership. And again, you see an amazing transformation the vast majority of the time in their daily routine in life. I think the other mention I want to get on is about HallQuest. So HallQuest was the second, it's debatable, like William and Mary and Harvard keep debating which one was the first university in America. In any event, HallQuest was either the first or the second inpatient hospice facility to open in the United States in 1982. And as many of you know, if not all of you, it was originally a grammar school structure. And in fact, we've had patients there who were grammar school pupils at that facility. And we ran it continuously for 40 years, but we had to close it because of wear and tear. And also, when it was established, hospice folks didn't really think about private rooms. So we only had 2 private rooms, and the rest were screened off sections, which is not ideal in any way, shape, or form for hospice. So at our newer facilities like Adler and Sibley, uh, every patient is in a private suite. And which also reminds me that unlike hospitals, there is no visitation hours. You can come and go as you please to visit your loved one 24/7. Live pets, as well as robotic pets, are allowed to visit the patient. And you can stay with your loved one around the clock if you wish, including overnight. And that was true at Hallquest as well. So Hallquest physically is a very large facility. We have a vision to do the following: to turn it into a center that provides hospice care for children as well as adults. So several rooms devoted to children. They can always be used for adults. Also, a clinic for palliative care for children and adults. Also, a section will be created for bereavement counseling. There'll be a pharmacy and a cafe. And the pharmacy and cafe will be open to the public. The pharmacy mostly to doctors. And so that's the vision. The challenge is to do all that is somewhere between $8 to $10 million for renovation. It's a 22,000 square foot facility. And so at the moment, we don't have that money. We're talking very actively to the federal government, as well as the state of Virginia, as well as to several wealthy individuals to try to get it going with a gift in the $3 to $5 million range. So we're hoping over the next few months that something will happen that will allow us to get a challenge gift going and start the renovation. But at the moment, there's no money that we have that we can start renovating it. But our hope is to do that. So I think I've covered most of what I really wanted to get across to all of you good people today.
Okay. One question I had is, Arlington is kind of legendary for how diverse our population is. How many different languages can you support in the hospice facilities and the home care?
Yes, well, we, in addition to English, we support very easily Spanish and Korean. And if there's another language, we can typically find somebody that can help us with the patient and family. I should mention that, and this is true of most not-for-profit hospice groups and some for-profit, we have about 600 employees, but we have 700 volunteers. And so the volunteers, some of them are language experts in their native tongue. And so we can rely upon them as well. And the volunteers do a lot of wonderful things, including phone calls to patients and their families, physically delivering food items and pharmacy items, and also pet care, walking the dog, feeding the pets. And volunteers also help to run our thrift store, which is a very active part of our overall operation. So we almost never have a situation where we can't communicate with a patient and their family. Thanks for the question.
Next question is, does Capital Caring have a reach beyond the DMV area?
Yes, as I mentioned, we provide the companion robotic pets regionally and nationally. As a matter of fact, we have a special part of that program, which is for veterans that have dementia. And we are soon to announce in a week or two that we're providing a whole bunch of these pets to every one of the 146 Veteran Administration run long-term care centers for veterans in the United States. all 146 of them, thanks to a grant that I received. And we also take the lead in working with other hospice organizations to provide expertise for care for advanced cardiac care, end-stage lung disease, and dementia. So, and our children's hospice group is contacted all the time from other hospice organizations who want to know about their special expertise. And so that's also a national effort that we do. And we work very closely with Children's Hospital here in the DMV.
How can people sign up to be volunteers, and what kind of training does a new volunteer get?
Right, a new volunteer gets pretty extensive training, depending upon what they want to do, and we give them all the various options. And we have a permanent staff that manage our volunteers. And if anyone's interested, they can go to our website and sign up, and someone will get a hold of them and say they're interested. So that's the easiest way to do it, by going to capitalcaring.org. And you'll see a button about if you want to volunteer. Or you can contact me, and I'll put you in touch with our volunteer group. And my email is scone@capitalcaring.org.
Does our local hospice support people who wish to use VSED, voluntarily stopping eating and drinking, when the patient and family agree and need hospice support at the end of life?
Yes, is the answer.
Okay. Do you work with the, excuse me, do you work with the Visiting Nurses Association?
I believe we do. And you know, another thing about hospice care that's misunderstood is, you know, people go, well, I'm giving up on life. And my response to that, and our response to that, is what you're giving up on is a better life for an extended period of time. Look at Jimmy Carter as an example, who's now been in for 7 months, and probably wouldn't have lasted that long if he hadn't been in hospice care. So again, it's so much better for the family as well as the patient. And tragically, people don't enroll soon enough. Oh, and they can always decide they don't want to be in hospice anymore. It's not a one-way street where you're enrolled in hospice and you can't leave. If the patient and or the family say, we've had enough, they can, you know, bail out at any time. So, but they get a better life. The family is much better off, and it's free. It's a benefit that everyone has access to. They don't have to be a citizen of the United States.
Okay, next question here is, this person says their religion strongly urges family members to sit with the dead until they're buried. And in the case of her mother, the hospital wouldn't allow her to do that, which was a very, you know,
Right.
unneeded pain to an already difficult situation. Does Capital Caring, are you doing anything to work with hospitals to make them more responsive to situations like that?
No, because they are impossible when it comes to that kind of thing. We provide any religious activity that is brought to our attention by any family, and we respect that. We have special training in many of the religions, including Judaism and its particular issues with death, but also with the Muslim community as well, and Hindu and others, as well as obviously Christian organizations. So we respect all religious practices, and we allow that kind of situation. I mean, the hospitals don't allow live pets. We do. Hospitals don't have 24/7 visitation. We do. Hospitals tend to over-medicate, and often, and I'm not dumping on them. It's just, that's, you know, they're not they're not community centers. They're not providing in-home care. They have hundreds, if not thousands, of rooms, and they have to have procedures. Often, about 20% of our hospice patients, maybe 15 to 20%, we care for in the hospital. We literally turn their hospital room into a hospice room because they're too fragile to move, unfortunately, home or wherever they were living. And so we come to them in the hospital, and in that room, family members can come and go as they please. But pets are an issue. Although we've been successful at getting live pets occasionally to the bedside of someone in the hospital, despite their restrictions. When the patient wants to see Fido or kitty cat, you know, in their last hours or days. And we work very closely with hospitals. Most of our referrals come from the local area hospitals. And, you know, they don't want people dying in the hospital because the government keeps close tabs on hospital mortality rates and has severe penalties if they rise above average. So hospitals are actually incented to work with hospice groups like us, and that's a good thing for everybody.
I see Mike has his hand up. Mike, if you want to unmute and ask your question.
Yeah, I mean, as briefly as I can, we did hospice with my mother, who was 96 years old in Arlington Hospital,
Uh-huh.
and she had eaten irregularly, and her kidneys finally were so the hospital. Nothing we can do anymore, and they called hospice, and hospice helped supervise getting her home, setting her up at home.
Yeah.
And when she passed, not too long afterwards, they came over and helped with the details of swearing. It was a great system. I'm very much in favor.
Right. Yeah, we do that. Obviously, we clearly the family is traumatized when the patient dies. And, you know, we work on all those details, what funeral home, what religious procedures. If it's a veteran, we have a special ceremony based upon their service area. We often have veteran staff work with veterans who are patients. We try to do that whenever possible, so there's a common bond. It's a wonderful service. We wish more people used it, and we wish more people used it for longer periods of time.
And we have a couple of questions about the Hallquist Center. How will the size and configuration change under the proposed renovation? Can you speak to the specifics of
Yeah,
what?
it will have 12 private rooms, 2 designated for children, but they can be used by adults as well, versus the 2 private rooms it had before. It will have a bereavement area, which includes private rooms as well as larger rooms for group settings. It will have a chapel, a non-denominational chapel. It will have a cafe for family members and the public with a separate entrance, and what's called a compound pharmacy, which is for a number of drugs that aren't normally available at a normal pharmacy because of the needs of end-of-life patients. And it will have a clinic for children as well as adults for outpatient care. So that clinic for children will be one of only 2 in the nation run by a hospice organization.
Okay, you mentioned previously that you're working on a challenge grant to get work started on the renovation. Can you talk any more about what else is being done to push your vision for the center forward?
Well, that's the big one. We still maintain all the grounds and you know, the air conditioning and heating and cooling systems in the building. But there's really nothing else we can do until we get a large grant. And it's not for lack of trying. So if any of you happen to be billionaires, I'd love to talk to you or know people that have that kind of means. And I know, you know, I'm talking to a couple of individuals that have that capacity. I think the state of Virginia is potentially going to do something, hopefully early next year, but you know, I can't say for sure that that's going to happen, but I've been talking to them about a $5 million gift, which they actually like one-time gifts as opposed to annual. So, you know, it's on their radar screen for sure. And when I say they, my staff and I have very good relations with all of the delegates in the Virginia Senate and House that cover our service area, as well as many that don't. And whether you like or don't like Governor Youngkin, he and his wife are big supporters of capital caring. And they have been for many years, long before he became governor. And so that's helpful for sure. And has opened a number of doors for us down in Richmond. But it's a challenge. It's a big challenge. And, you know, there's no good news at the moment. I haven't secured any funding to renovate.
Does Capital Caring provide hospice care at retirement facilities?
Any facility, any facility where a terminally ill patient resides, we provide care.
Who are the usual members of a hospice team?
Yes, there are usually 3 levels of nurses, with the highest being a registered nurse, and then certified nursing associates are probably there most frequently, as well as, so the team is several different types of nurses depending upon the daily needs of the patient. Social worker and a chaplain if the family and patient want one, and of course a doctor, a hospice trained doctor. So that's the core team. And I like to say that we're visible when you need us and invisible when you don't, so that we try not to impede on the family living situation in any way. And I make that point because on a national level, and it's true here as well, of those people that are qualified for hospice care, 85% are Caucasian who enroll in hospice care. 85% are Caucasian, 8% are Black, 6% are Hispanic, and 2% are Asian, which is, you know, terrible. Washington, D.C., which is 50% Black, has the lowest, the next to the lowest hospice utilization rate in the nation. So if you look at the 50 states plus Washington, 51 in total, Washington is 50th in hospice utilization, which is terrible. And Virginia isn't great. Virginia is 32nd, which means that a majority of hospice qualified patients in Virginia never enroll, about 60%. So I'm actually trying to get a hospice awareness campaign started early next year for the entire state, not just for Capital Caring, but for all the other not-for-profit hospice groups, with state funds and private insurer funds to try to make the case that people should be more aware of hospice, especially with the aging of America, and what an incredible benefit it is for the patient and the family. And we're also going to be launching a campaign in Washington, D.C., I believe in November and December this year on hospice awareness, focused primarily on people of color and the gay community.
Where is the Hallquist Center located?
Across the street from the hospital, that big hospital center, Virginia Hospital Center.
Okay. What was the reasoning behind the recent affiliation with a group in Florida?
Yeah, they're called chapters. They operate in most of Western Florida, from Tampa on up to Tallahassee and over to Orlando. And they also operate in Georgia. And combined with them, Capital Caring with them, we're the largest not-for-profit entity, hospice entity in the United States. So there are three major benefits of this affiliation. There's no name change. It wasn't a financial transaction. We share best practices, and we share back office systems. That's number two, which means that we have more leverage because we have 4,000 employees in total. So we have more leverage of medical suppliers as a result, and also more leverage with benefit suppliers to the combined employee base. So that's really the reason for the affiliation. It has nothing to do with our operation here, nothing to do with our philanthropy, and nothing to do with our brand name. We have the same mission because they're a not-for-profit in our network. And I should mention that if you go to the Capital Caring homepage, you'll see our 24-hour, 24/7 care number, but you'll also see an 800 number that you can call if you have a loved one, friend, relative who don't reside in the DMV, and you'll be, if any other state in the country, you just say, my mom lives in Austin, Texas, and they say, well, we'll put you in touch right now with the not-for-profit palliative care hospice group right there. So that's a major, major benefit for people because, our families are scattered all over the US, not just here.
Is Capital Caring the only nonprofit hospice in the area?
No. But in our service area, we are for the most part. In Loudoun County, we share a little bit with Hospice of Blue Ridge. And in Maryland, a little bit with Gilchrist, they're both nonprofits. Gilchrist is headquartered in Baltimore, and Blue Ridge is in Western Virginia, out near Charlottesville, I believe, is their headquarters. But there's only 3 of us in this entire region.
Do you know how the plan for hospice is determined? Who's involved? What about family members?
Well, yeah, when a person is enrolled, the first thing we do is the doctor, and usually it's a doctor and a nurse, sit down with the family and the patient to the degree the patient is responsive and discuss the plan, what's going to happen, how the treatment is going to occur. And to be specific, children are different, but with adults, our mission, which is regulated by law, is to provide comfort in a pain-free environment. We are not curing anymore. And in fact, curing is a problem because it often reduces the life of the patient by weeks and months. Because, the family or the patient want to keep chemo going, for instance, and it actually has an adverse effect at some point. So none of that happens in hospice care. There's no curative treatment going on. it's pain-free treatment. With children, it's different because of a law passed in 2010, where we're trying to cure the child as well. It's called concurrent care. And that's because many of the children are babies with birth defects that, with proper medical attention by our staff, can sometimes be overcome. But in any event, so did I answer the question?
Yeah, I think so. If somebody's in hospice care for more than 6 months, do they get recertified? Is there a reexamination?
Yes, they have to be recertified in order for Medicare or Medicaid to continue to, support us. That's sometimes a patient gets better. About 15% of the time we release them after 6 months or even sooner. The term is release, which means they no longer need hospice care. Eventually they will again. But so that's an important point, which is it's not a death sentence necessarily. Hospice care extends life, and often people recover. Not often, but 15, 20% of the time for some period of time.
Is there any kind of a lifetime limit? You said if you release somebody, they likely will be back. Is there any kind of limitation on that?
If they come back, then the meter starts all over again.
Okay.
Yeah.
I have a question here. Can you talk a little more about palliative care? What is it? Is it often offered at Capital Caring, and what health conditions qualify?
Yes. Palliative care is for people living with a serious illness, and or more, one or more, and the goal is to treat that illness. So the only real difference between us and a hospital is it's mostly in the home, and it's family oriented. So the whole family, just like in hospice care, we talk about the plan with the whole family that's present. Or even if they live in different parts of the country, we talk to them by phone or Zoom. So we're all about family. And if a person doesn't have a family, and there's plenty of those people, more people living by themselves today, probably in America than ever before in previous generations. That's why we have volunteers too. So a volunteer can kind of serve as a family member with frequent visitations to someone living on their own, if they're not in a assisted living facility or a nursing home. But if they're in a residential apartment or a home and they're totally by themselves, we also can help with that. We also provide this care to the homeless and or people that are financially challenged. We've had several cases recently where people were going to be evicted from their apartments and we pay the rent, as we're providing palliative care and or hospice care. So you're not going to find any other institution, and definitely not the for-profits, doing that kind of thing. And when I say we, that's pretty much true of all not-for-profit hospice palliative care groups around the country. And I helped to run that association of 100 groups. It happens to be 100. It's not a made-up number. And collectively, we care for probably 500,000 patients and families a day. And on an annual basis, millions of family members, and so on. Same mission. All of us have the same mission. Regardless of race, citizenship, or ability to pay, we're there for you.
Are there specific health conditions that qualify for palliative care, or is it just a case-by-case determination?
It's case by case, but it's you know, pretty much, not pretty much, certainly every major affliction you can think of, you know, and it's one thing that brings that to my mind is often doctors as well as families don't understand that dementia is a palliative care and a hospice care disease. And for some reason, people don't know that a lot of the time. I mean, Medicare talks about it in their booklet. I'm not sure how many people ever read it, but dementia is a qualifying disease for palliative and hospice care, as well as obviously cardiac care, end-stage lung disease, um, um, and all forms of cancer, um, and kidney failure, and so forth. So it's really any serious illness. And what is serious? A family should call us or their local not-for-profit and describe the patient's situation, and then we'll tell them. And if it requires a visit, which it often does, we do that. So really, we're really a lifeline, safety net, if you will, to specifically for us, to families here in the DMV. And our goal is to treat people in their homes or wherever they reside the vast majority of the time, to mitigate and not make necessary 911 calls, to avoid hospitalization, and to age in place at home, which I believe is your mission as well.
So what do you see as the future for hospice care? Are there evolving trends or technology that you see coming down the pipe?
Yeah, a few things for palliative as well as hospice care. I should have mentioned, so I will now, that we Capital Caring are leading the nation in providing in-home ultrasound. So we have mobile ultrasound devices, which means you don't have to somehow get a homebound patient off to a clinic or a hospital for ultrasound treatment. And by the way, it's much, much, much cheaper than that, and much, much, much more convenient for the patient and family. And we also are providing virtual reality equipment for the patient and the family. So a patient can in one sense, have their last wishes fulfilled with these special goggles. You know, I've never been to Paris. I want to go. I want to see my childhood home. I want to visit all the Navy memorials around the country. I want to take a trip to outer space. Pretty much you name it, and we can provide it through this affiliation we have with this virtual reality company. And so I think another answer is as the boomers age, hospice care should become more popular if it's well understood. And no family should have to go it alone. So here at Capital Caring, we're trying to get the message out. I received grants, so I can do TV, radio, and other as well as social media promotion of these benefits. And I continually try to do that. I'm not sure. The only other thing that may happen at some point, I wish it would, is providing concurrent care for adults like we do for children. Meaning, in some cases, maybe we should try to cure them, but we're not allowed to now if they enter hospice care. If the family wants to pay for it, they can, but it's not covered by insurance. So, and doctors are also to blame to some degree, not all of them by any means. But many doctors refuse to give up even when it's patently obvious that there's nothing else that can be done. And so that's why we need to educate physicians as well as, residents of the DMV on the hospice benefit primarily. Because physicians don't like to admit that there's nothing else they can do. And that's a disservice, which the family needs to be, able to push back and say, well, I don't think Aunt Millie really is in any condition to receive additional care. And in fact, it's hurting her more than helping. So families should speak up and be educated, particularly about hospice care. And for palliative care, as I said earlier, a lot of our palliative care is for people that can't get to the doctors. And as we all know, doctors haven't been making house calls since I was a kid. So for the most part, except our doctors. So, yeah, we really do have a special mission. All of the residents of Arlington should, the more you can spread the word, the better.
Steve, I was just going to ask a quick kind of supplemental question to that, and that is, what if there's a difference of opinion in terms of, say, the person who is actually in hospice versus the family? Because sometimes it's a matter of the family wants to prolong the life of a loved one, whereas the loved one is ready to go. And what happens in those kind of situations?
The short answer, Cheryl, is nothing good. So we can only come in if we're asked to come in. So is the patient going to call us on their own? If they do, we will come. And if the family has a problem with that, it doesn't happen. What I just described doesn't happen very often. What unfortunately happens is we never hear about it. So that's just too bad. It really is. Because often the patient isn't able to, on their own, contact us and ask for us to come visit them.
Right.
I have another question. How can those of us with a few extra dollars support capital care?
The easiest way is to go to capitalcaring.org and hit the donation button. And if you don't mind giving us a credit card gift, which is totally secure. And by the way, if you go to our website, and that reminds me of two other things. If you go to our website and hit the donation button, you'll also see about 15 different areas that you can support. So you can either give us money for use it capital caring as you see fit, or I want it designated for this, and this, or any one of them, including the PETS program, cardiac care, inpatient care. All of that is listed. If you want to send a check, you can make it out to Capital Caring and send it to me, to my attention here at our headquarters. If you want to do, if you want to send stock or ACH wireless or wire transfer, I can send instructions for that. But the easiest way, assuming everyone has a credit card, is just go to capitalcaring.org and hit the donation button. Thanks for asking.
I guess it looks like we have time for one more question yet, Gary.
Yeah, and the question is, what happens in situations where the palliative care people are saying hospice is needed, but the other team of doctors wants to do aggressive care? When the doctors disagree about whether hospice is indicated, do you counsel the family, or how do you?
Yeah, we definitely counsel the family. Now, bear in mind, most of our a lot of our palliative care is for homebound people, so they're not seeing doctors. They're no longer able to go visit doctors' offices. But we don't say doctors can't come or talk to them. That's totally up to them. And if there's a doctor disagreement, which doesn't happen very often, by the way, when we're involved, we try to work through it. But ultimately, the family and patient have to decide. If they want to bail out of hospice care or palliative care, they can.
Okay, well, I think we've finished all the questions and we are now at 11 o'clock. So Steve, thank you so much for this excellent presentation about capital caring and giving us a tutorial about the difference between palliative care and hospice care and the many services and programs that capital caring offers. It's really was very helpful, and we want to thank you for that.
My pleasure, and thanks to all of you for having me as a guest today.
Okay. Well, and I just wanted to remind everybody who is on the screen here and those who aren't, if we want to remind your friends and colleagues and family members that next week the guest will be, the discussion will be about saving Claire. That's September 18th through the 22nd is National Falls Prevention Awareness Week. And so there's going to be a groundbreaking documentary showing of a documentary called Saving Claire. And there'll be Q&A afterwards, and talks about aging and the increase of fall risk amongst older adults. So definitely want to tune in at that time. So, and Arlington Neighborhood Village is proud to be a sponsor of this important project in the DMV area. So be sure and check it out. So until next week, I want to thank you all for joining us on Coffee and Conversation, and our excellent speaker as well. And I guess we'll see you next week.